Um, Hopefully you can see this in full screen. Essentially, national PEWS is based on four elements. You have the PEWS score, which I think people are aware of or will have seen before from their local PEWS charts, which is a heart rate, respiratory rate, saturations value, which gets into a number. You add all those numbers up and you get an overall score. Along with that, there are also some ways of escalating based on specific concerns. These are to do with level of alertness, essentially AVPU, or particular criteria related to the score around sepsis, which I'll come back to. There is also the ability to independently escalate based on clinical intuition and caregiver concern. And I'm going to come on to caregiver concern and Martha's rule at the end. On the chart itself, contributing to the score, respiratory rate, respiratory distress, and everything on that left-hand side. I don't think there's anything particularly controversial there. On the right-hand side, which does need to be measured but doesn't score, but which you can escalate through a parent concern, caregiver concern, temperature, and AVPU. What I've highlighted in red are the things that have been sticking points and are potentially sticking points in a children's emergency department. Blood pressure in particular is one of those VEX things where you don't really seem to need to do it and then you realize you did. And I think most of us perhaps have been involved in cases where blood pressure wasn't measured until a late end stage of disease. And then it's difficult to demonstrate that that child had had a normal blood pressure. It's a bit like sepsis as well. One of those things you wish you'd measured or after the event, but never felt you needed to measure beforehand. And we'll come up with how we've dealt with that. Caregiver concern I am going to come on to because I get that can be perceived to be a challenge. And temperature is an issue in the fact that it doesn't score on the inpatient chart, really because there isn't a direct correlation between temperature and outcome. In the emergency department, though, I think if you've got a 2-week-old with a fever, you'd probably want to know about that. But on the chart as it stands, the temperature may be measured, and we've highlighted where an abnormal temperature is, but you wouldn't score. And that does mean you probably do need to have some different sepsis type systems to be able to pick that up. But we can talk about that at the end. This, on the face of it, looks complicated, but should be relatively intuitive. The PEWS system is predicated basically on low, medium, high, and emergency acuity bands. And that's the language that I wanted people to start discussing in, rather than go, I've got a patient with this score. It's I've got a patient in this band, and this allows communication, hopefully in the big scheme between the community, pre-hospital, ED, inpatient. So we're all using what we believe is a similar acuity of patient. And so low can be made up of either of a score of 1 to 4 or caregiver concern, clinical intuition based on that low level. Then you've got the same for medium, high, and emergency. And just to highlight how sepsis fits into all of this, because this is relatively relevant from a PEWS score point of view, what we've done is ditched NICE, as it were, because I don't think the evidence was supportive of the current physiological values applied to the patient cohort we see in the emergency department, and go with the Academy of Medical Royal College's approach, which says if you've got an NPEWS score of 5 to 8, you need to be considering sepsis there, but you've got 3 hours in which to make a decision. If you've got a PEWS score of 9+, which is pretty difficult to get, actually that child is likely to be sick. And then that's when you would go, look, you've got an hour with which to make a decision and deliver antibiotics if that is needed. And so highlighting, I think from the escalation point of view, that's how we've embedded the sepsis screening, and I can do a whole other talk on why I don't like screening as a term, but that's how sepsis fits into the NPEWS escalation cascade along with scoring. Now, again, this isn't a great slide to do as a presentation because there's so much text to it. But it's essentially saying for each of the low, medium, and high and emergency brackets, that is made up of either the specific concern, clinical intuition, caregiver question, or the score. That leads to then some actions. And then those actions lead to medical review and a minimal observation rate. Now, the chart I'm showing here is the inpatient chart. We will quickly review the ED chart, which is similar but not exactly the same because of reasons of heightened acuity in the ED cohort and not wanting to have the registrar have to review every child that presents. So we have the framework of the NPEWS system. From an emergency department perspective, we have this vexed question of triage and assessment. Now, this is a slide taken from what was planned to be the national triage and assessment approach, which was also going to be standardized. That is now not going to be the case for 26-27, but the principles of having primary assessment, i.e. you walk in and someone makes a decision, i.e. you're really, really sick, or that you're not sick at all and you can go away. And then you go on to secondary assessment, which is essentially what we commonly know as triage. Now, from a pediatric standpoint, that there was a real push to have acuity 5, which is you don't need to be in the department at primary assessment. I know lots of people are quite uncomfortable about that on an eyeball, so you don't need to do that as part of NPEWS. And some of these patient groups of 20 to 40% being able to be acuity 5, I'm not sure completely stands for the pediatric cohort, but one of the great things about doing NPEWS is that we'll be able to collect data over time and work out kind of what these brackets are. But as a child arrives, there are some specific groups that we can put them into. So I think everyone is going to agree on what the left hand says, which is immediately life-threatening. These are the patients, you don't pass go, they get grabbed into kind of resus or HDU, and people do things to them immediately. Then there's the next child who has to be seen, and there's a list of features there. And then there's anything that doesn't need to be in the ED. You're then left with a group of people who aren't 1, 2, or 5. And in that group, they're the people waiting for secondary assessment. Now, for that group, there is a prioritization. So if you've got a bit of respiratory effort, maybe a non-blanching rash, you've got a fever and you're less than 3 months old, they're the people that you want to be prioritized for secondary assessment. And in the intercollegiate document, they make that clear so that they want assessment to be done within 15 minutes. But if you can't meet 15 minutes, you need a prioritization process. And this NPEWS meets that prioritization process. So essentially, what you have is when you arrive, you get an acuity level 1, 2, 3, 4, 5. That corresponds to the escalation levels for NPEWS. When you've arrived in primary assessment, you're either immediate urgent review or you await secondary assessment, or that that level 3 is prioritized for secondary assessment. And then you have the secondary assessment, and then you basically are in your blocks of low, medium, high, because that's what NPEWS is telling you to do, and you get an outcome commensurate with that. So essentially what I've tried to do is mix initial acuity levels, and you can use, if you're using MTS, there's no reason why you can't continue to do that. But it fades into how NPEWS would work. This diagram is exactly the same as the previous diagram, but as a flow model. So you arrive, you get your primary assessment, you get escalated or you move on to secondary assessment, and then you get ongoing observations, either dependent on your triage score between 1 and 5, or your acuity risk, high, emergency, medium, low, etc. Locally, we use something called DPS. Doesn't really matter what the triage score is called. A colleague of mine, Gareth Lewis, came up with this great phrase: 1, 2, bring them through; 3 or 4, wait some more; clearly 5, you'll survive. As a way of just kind of remembering how that system works. Now, for initial clinical presentation, you go into these aliquots of 1, 2, 3, 4, 5, or emergency high, medium, and low, based on some I think, relatively easy descriptors. Now, Manchester Triage Score has a system, ESI has a system, and there is no reason why you can't put those systems and just use them as your way of generating the 1 to 5. My personal feeling is, and we've been working on an ED and triage system for some time. BIML was part of that group as well. It's a shame it's not moved forward for a standardized approach, but I think we've been using this similar type of system in Leicester for some time, and I think you'll all recognize something similar in your own departments. So I think it works as a way of differentiating those children at the front door. As you then move forward, you've got what do you do with a particular NPEWS score as you start taking that. Now, this does become tricky. Those minimal observations, I suspect we've not got completely right yet. So that if you're in an NPEWS 0 to 4 and you're in the 4 triage category, what we're saying is that most children should be reassessed within an hour. I think that's really logistically demanding to do, and certainly in Leicester we can't give everyone hourly observations, but it's a target to aspire to. I think most children who have higher scores, you do try and do hourly obs, or more frequently as you get more sick. But again, once we've got more people on board with this, we can start to refine what that minimal response would be. So just coming back to some of the challenges I mentioned, from a blood pressure perspective, I'm really sorry, it's really difficult to show the chart via a PowerPoint presentation, but it is easily able to be downloaded. But basically, the chart itself gives you brackets of care to move towards. White being no score, yellow 1, orange 2, red 4. I think that's relatively self-explanatory. But just at this point here, for blood pressure when you arrive, you can record it, but it doesn't score. And this is an important digital principle, that when you move to a digital system, you really do have to put a number in and you have to create an action. It's easy on paper not to do something, but from the inpatient NPEWS point of view, to create a score, you have to put in a number in, and the only derogation you're allowed is for blood pressure, and that's what we've adopted in the ED. So you don't have to do a blood pressure, and you can still generate an NPEWS score. At some stage, you flip over and you see this big white band in the middle of the screen. So on the left of that is triage assessment, initial observations. At some point, you'll move to the right-hand side of that, and that's essentially the same as your inpatient NPEWS. I was hoping to have more data by now, but we just haven't done that. So what we're saying is, either the clinician decides, or you've been in the department for more than 4 hours, or someone's made the decision to admit that patient, you're waiting for a bed, and those things would move you to the right hand side of this chart, just going on to normal inpatient NPEWS. I've also mentioned some of the challenges with caregiver escalation. I've used this slide in teaching lots of times to highlight that this challenge between the difference between what a caregiver is concerned about and the guideline that a clinician is working towards. And this is really evident in the emergency department. I've already done some research showing that if you use POPs, which is the kind of the NPEWS equivalent we have in Leicester, that 10% of parents who, if their child scores 0 on POPs, 10% of parents who score their highest level of concern that they've got have a POPs of 0. So there's lots of caregiver concern which isn't balanced by what is the child in front of you, and that does create a problem in the utilization potentially of Martha's rule. Now, as it stands, caregiver concern is a professional activation. So that caregiver concern, that the nursing staff or medical staff feel the concern that the parent has, and then they escalate according to that. However, there is also now a caregiver activation, which is Martha's rule. To be really clear about this, Martha's rule is adopted on inpatients. There are a couple of sites that are looking at Martha's Rule adoption in ED, but there is no national mandate, regardless of what you may have heard locally, but no national mandate to put Martha's Rule into the emergency department as it stands at the moment, because we really aren't sure how it will play out in comparison to other measures of escalation. And so we're trying to get data on that. And essentially, my future hope, is that we combine that escalation. So you shouldn't need Martha's Rule and both national PEWS. We've got to the stage where you've got one measure of caregiver concern. But as it stands, that caregiver concern comes through the nurse, and that's how that escalation works. So that was kind of a real tour de force on where we are up to with ED NPEWS. I'm going to stop sharing now so I can see everybody. The heart rate, respiratory rate values are the same as they are on the inpatient chart. There's a bit of controversy about that potentially. We've had some queries about the heart rate level on NPEWS being at 150 for the 0 to 1 group rather than 160. But I know some of the places that have used this already haven't run into massive difficulty with that. It is slightly at odds, I suppose, with the NICE sepsis guidelines, but that's why we've moved away from NICE sepsis for this and gone from the academy approach. So I'm going to stop there, take a deep a breath, and let people come in with challenges, queries, concerns, etc. As I said, it's recording, so even if you think of something after the event, or you want your colleagues to see this, we can ping this on for discussion. Tony. Oh. Tony, I'm really sorry. Your voice isn't coming through at all. Is that just me, or is that everyone? No, okay. Tony, I think you're going to need to put your question in the chat because none of us can hear what you're saying, I'm afraid. Sorry. Any other? Rachel.
Hello, everybody. Thank you so much, Damian. That was really helpful. I wanted to pick apart a little bit about when we flipped the inpatient side. I'm sure we're not alone in having patients in the department for varying lengths of time, and I think I guess I have some concerns about trying to get our nursing team to use 2 scores at the same time, depending on where they are. Would it be up to individual departments to decide at what point we do this? Is that what's that process? What do you envisage that process looking like?
So I didn't want to be in this situation, if I'm really honest, because we've been piloting ED NPEWS for quite a while now, and I was hoping that there would be more digital sites on board, that we would have tested this over a longer period of time, so I could give you a definitive answer about what the safest thing to do is. And unfortunately, we're not in that situation. But we do need to move forward with being able to show people where we are, because of the feedback I'm getting is, look, Damian, I can't build ED NPEWS, or the trust are waiting for ED NPEWS to come out to build the inpatient NPEWS. So we're going a bit earlier than I'd like. I think you need to decide what you'd like to do from what's safest from a local governance point of view. Now, the chart, the left and right hand side are only really different on that blood pressure, whether it scores or not. It's not as if you're taking different obs or you're scoring them any differently. So I don't think it's a massive challenge in terms of what the nursing staff do. I get, though, that decision probably needs to be universal. What you can't have is individual clinicians on the shop floor making different decisions. So as a unit, you need to decide, okay, is this consultant only, or is this time-based, more than 4 hours, or admission-based, or a combination of any 2 of those 3? But that will be up for you to decide what you'd like to do to begin with until we've got more evidence. Is that okay?
Yeah. Yeah, great. Thank you.
Sarah, and then I'll come back to your questions, Tony.
That was just with the same thinking about the same thing. I mean, I can't pretend that I'm very au fait from a digital point of view, but we are digital. And what I've found going through things is that with regards to digital, moving over to different scoring systems on a digital platform, there's got to be some sort of change or something different. So it's not like you can just, because with the ED the escalation is basically what's different, isn't it? Because of the fact that you're in an emergency department. So there would have to be, for us anyway, from what I'm understanding, having gone through the inpatient PEWS, it'd have to be something different about the next set of PEWS to be an inpatient PEWS. So it would have to be that when you're in this location, for example, you're on the ED PEWS, but when you're moved to this location, we can change it over to a different PEWS. Or like you said, maybe it's a time frame that if you 4 hours from when you've arrived, everything changes over, but there would have to be something specific from a digital perspective that changes you over. It couldn't just be, a bit floaty or up in the air, because that wouldn't work from a digital perspective.
Yeah, so from a digital perspective, I mean, things like time and location are really easy. It is one of the reasons that I wanted to get this nailed down, is to get the digital specification going, is because it is possible, if the digital provider knows in advance, to create user facilitated change. And I know that to be the case, because certainly for our digital provider in Leicester, it is possible for the user to switch between scores. And that can be done digitally, but that, as I think Rachel was alluding to, that user-defined approach I'm the least comfortable with, because that allows variation within the department. So I think it is likely to be probably time-based, or there is something that you change. So moving a patient from being to be admitted or not, or at least on the bed list, again, is a digital change which will allow some of this to go on. I agree. I'm least comfortable with the user-defined version, because that's, one, digitally more difficult to do, and two, because it allows for variation. Cool. So who is next? I'll just come back to Tony's question. We use MTS and then triage, then stream to relevance. So the acuity model should work no differently to MTS. And as I was, MTS can still work with this, because you could use your MTS, which is 1 to 5, and then just switch to the NPEWS approach when you've decided a patient's going to stay in the department, or you've done those first set of obs. Now the NPEWS at triage, I think is an interesting thing. The reason we've separated primary and secondary is, primary is saying is you're not doing a set of obs. At secondary assessment triage, the intercollegiate guidelines really clear on this. You need a set of vital signs. And that's, so there isn't, the MTS shouldn't be a get out of jail free card for doing a set of observations at triage, because that is what the intercollegiate guidance says we should be doing anyway. So I'm not going to apologize for NPEWS to ask for that to be done, because I think that is already a standard. Okay, Elise.
Hi, thanks, Damian. We've had lots of the same conversations about when to move over when we've been talking about any obs scoring, and when the inpatient wards went on to NPEWS, when we should switch over. And there was a trial of switching in the department at the point that there was a DTA, and it all got very complex because we're digital within the department and they're on paper still on the wards, and it caused all sorts of chaos. What I wanted to ask was, do you know when it is formally going to be coming out? Because we were looking at moving over to using POPs. We're not using POPs at the moment. We were looking, sort of starting the build of that into Cerner. And if this is going to be imminent, I know it's been sort of delayed a bit, but if it's imminent, then there's no point in us moving over to one to then move over to another. If there's going to be significant delays, then it still makes sense for us to do that.
Yeah, thanks. So, I mean, given POPs has been my baby for a while, it pains me to say this, but I wouldn't build POPs into Cerner, because this is what is going to come. One of the reasons I wanted to have this session is because I got very nervous post Christmas and the New Year that we just weren't moving forward for all the reasons you're saying, that people want to know what the model is. And so I think what we're going to try and get out is what's called a prototype digital specification, which is a word salad really, but it will enable people to see what the product is like, even though we're not completely endorsing it, but it is then out there for digital providers to be able to start building stuff. And I'm hoping to be able to do that in the next 4 to 6 weeks. So you've got something to work on.
And sorry, one other thing with the digital build of it, I will go back to our digital team about it, but are the build issues with the actual visibility of the chart rather than the input of data?
There are certain digital providers who are having difficulty with some of the visual requirements of this.
Yeah. So in theory, if it wasn't, because it's not going to have to be implemented immediately, is it? If we were looking at moving over to an alternative scoring system, we could in theory build in the data collection part on Cerner whilst we're still having issues with stuff, use that as a numerical score without the visible chart until all of the other stuff is resolved, right?
Yes.
And then it aligns better with the inpatient stuff. It's only the blood pressure. And so with the blood pressure, just to be really clear, it's just that you can calculate an overall score without blood pressure. And then when you do add in a blood pressure, your score can go up by up to 4 points.
Yes, and we appreciate that that is a potential risk and confusion point. I've yet to be able to find a way of mitigating that without making blood pressure mandatory earlier in the pathway. And those people who have been using it so far haven't highlighted that that is a real problem. So I think it is a reasonable assumption to say that's the way we're going to go.
Perfect. Thank you so much.
Okay, no worries. Right, Tony, and then Niall.
Yeah, can you hear me better now, Damian?
Yes, yeah.
Yeah, wasn't sure what was wrong with my earphones. Thank you so much. I think typing, I couldn't clarify what I was saying. So at the moment, we use NPEWS once they come into secondary assessment. We do the MTS and have a basic set of obs. Once they come into the back room, we then suddenly flip onto NPEWS, which they use on the ward as well. So the reason why I was raising the argument was if we're going to go over to a different version, well, it will need training, but it might be that we're actually in a better place now from a Lewisian point in the sense that we're changing our whole EPR system in the next 1 year to EPIC. So it might actually give us some room to build some of this in and be able to get this out there as soon as possible. So I guess my question is, how soon do you think this will become, for us to be able to push it to be built into our EPR system?
So I've muted myself. Yeah, so really good question. I wish I could give you a definitive answer. What I'm going to try and promise to do is that there will be something at least publicly available in the next couple of months. When we get to the stage where, a bit like the inpatient PEWS, there is something on the NHS England website and the RCPCH saying this is what you need to do, I think that's going to be much later this year, if I'm honest, probably towards the end of the year. But I do think there is such a weight of push now towards digital transformation that once we've got at least the EDM PEWS prototype out there, you will be able to argue with your trust and digital providers that this is what is coming and this is what should be used.
Cool, thank you. We've got 18 months anyway till the rollout, so yeah, hopefully we can have some time.
Winner. Niall.
Can you hear me okay, Damian?
Yeah.
Yeah, sorry, I'm in a different office. I didn't know if I was going to be picked up. I was just thinking about the categories you said, the little rhyme you had about 1 and 2, 3 and 4 and 5. And correct me if I'm wrong, but my understanding was the 5 category are the ones that we potentially stream away to urgent treatment centres and so on. Do you have any idea of the sort of, is there any likely massive, I know people use different categories for streaming away at the moment, but any likely big changes in terms of the numbers that will apply to, in terms of numbers of patients, that will that change massively? And I guess the second question from our end, particularly with a co-located UTC, have UTCs been involved in, because we use a sort of POPs on both sides at the moment in UTC and PEDS to aid streaming, are they involved in implementing NPEWS at their end as well?
Yeah, so the 1 to 5 actually comes from the emergency care data set, and that isn't going to change. So I don't want to be 100% confident, but I'm 99.9% that we're always going to have 1 to 5. 5 is always going to mean that you're redirected kind of offsite, or you don't need emergency care, and that 1, 2, 3, 4 are commensurate as to how I discussed. I think that's relatively fixed now. With regard to the UTC point, now that the ED, the model ED document has been released, we need to start working on what other providers are going to offer as part of their ED offer. Part of that will be what the kind of the model UTC offer is. And I think there is going to be discussions about how NPEWS interplays with that. Most big UTCs now probably do need something like NPEWS, and I know certainly locally all of our kind of UTCs do use a POPs or POPs equivalent. So I think that will come. It's just not being completely nailed down yet. Bimmel, and then I will draw things to a close.
Thanks, Damian. I think that's really helpful. I'm pleased about the sepsis stuff, and that's being drawn out slightly differently. Do you know? And I liked the ditched nice. How have you had any conversations about how CQC are going to feel about that, and doing this slightly differently? It's just probably not a barrier that we want to come up against once we start to implement this.
There is a CQC statement. I should have had it ready and prepared. I will put it in the comments that specifically addresses that question. So the CQC, during the process of doing NPEWS, CQC would take that into account in terms of any review of your site. They are very well aware there's going to be a change, so that you shouldn't feel worried about moving to the NPEWS sepsis approach. In the, I don't know if anyone's applied to be part of the NICE sepsis under 16 guideline update in this group. I'm hoping there should be at least one PAM person, but NICE have specifically said they want to integrate NPEWS anyway. And I've had lots of discussions with them about them. It has been a slightly frustrating couple of years, but I think we are now in a position where probably the NICE guidance is going to change as well. But the CQC are very supportive of this approach, and I will stick that link in the chat. Brilliant. Thanks all. I appreciate that was short and sweet. There may well be other questions that people want to kind of ask me offline. You can certainly do that via the Heads of Service WhatsApp group. I'll make a recording of this. I can share that via the WhatsApp group to share to others. And if we need to convene another meeting, perhaps in 4 to 6 weeks, to go through things that have turned up from this, I'm very happy to do that as well. Excellent. Thanks all.